two types who are infectious to humans. These are the Delta retroviruses, which contain the HTLV viruses, and the lentiviruses. And the lentiviruses contains the HIV-1 and HIV-2 virus. The HIV-1 is more infectious and more ready to go from person to person, more infectious than the HIV-2. So we see in the clinic far most people with HIV-1. The HIV-2 is easier to treat, but I've never seen one in my career. I've always seen the genotype 1 patients, never seen the 2. Researchers agree nowadays that most probably the HIV virus comes from the simian Immunodeficiency Virus, which is found in apes in the western parts of Africa. And how the first person got infected, we still don't know. But we see similarities between the SIV and the HIV virus. In 1981, a curious thing happened because in San Francisco they started seeing patients with a rare tumor, cancer type of the skin, the Kaposi sarcoma. And this was very rare, never seen in patients with good immune systems. So this was, they thought this was strange, so they researched this further. And they also saw a lot of cases with pneumocystis carinii infections, pneumoniae infections, in formerly healthy homosexual men. So this is a new syndrome, which first was seen in 1981, and they called it the acquired immune deficiency syndrome, so AIDS. Not until 1983 they found out which was the cause of this syndrome. And in Paris, Montagnier was the first one to discover the virus, the first one to actually clone the virus in the laboratory. And this was very soon also found in the USA by Gallo. So nowadays there's 30 to 35 million people infected with the HIV virus, so it's a pandemic infection. Why is it a problem? Of course, you already know a lot of this stuff, but when you don't treat the HIV, it causes the AIDS. I will tell you a bit more in a few slides. And AIDS can lead to death. It's easily transmitted to other people, and the thing is, a lot of people don't know they're infected, so that's why it's easily transmitted to others. AIDS is a term we nowadays don't use often anymore. It's more, we speak of HIV or severe HIV. The term AIDS is not quite often used in practice anymore. How do we define AIDS? So as we used to define it, you have to have a positive HIV test, of course, and you have to have a combination of rare infection or rare malignancy in these people. And this is a list you don't have to know, but I'll give it to as an example. So the pneumocystis pneumoniae, pneumonia, is an infection you don't see in people with a normal immune system. So this is one of the age-defining illnesses. And also esophageal candidiasis. Sorry for my pronunciation. I meant this one. It's also one you don't see in healthy people. And toxoplasmosis, lymphoma is also one. Of course, people with a normal immune system can get a lymphoma, but we know that in HIV, it's more you're more prone to developing lymphoma. So if you see one of these infections, beware that your patient can have HIV. Prevalence by country. Of course, we all know in Africa, in the southern part of Africa, there's a lot of AIDS, a lot of HIV prevalence. But also in Asia, there's a lot of big parts where HIV is, where a lot of people suffer from HIV. In Africa, this estimated 22 million people living with AIDS, with HIV, I have to say. And we see that in Africa, actually, the new infections are going a bit down the last years, while in Asia, the infection rate is going up the last couple of years. In western and central parts of Europe, it's more or less a stable number during the last years. And also a lot of newly infected patients we always see. This is a bit old data, but the numbers didn't actually change that much in the last year. Apart from what I just said, Africa is going a bit down for the new infections. Asia is coming a bit up. And also still a lot of people dying from AIDS. We nowadays say when you get HIV in Europe or in western parts or in northern Africa, I must say, then you don't have to die from HIV. It's very well treatable disease nowadays, but of course in parts of the world where medication isn't there to be given, a lot of people still dying. So this is, I must say, I found it quite shocking numbers. You see from the 1950s until 1980, the life expectancy of the people living in Zimbabwe, South Africa and Botswana, these are the dotted lines, went up, as well as Madagascar, Senegal and Mali. The first three countries are countries where HIV is in high prevalence, and the other three countries is where a lot less HIV, there's a lot less HIV among the people. And you see the lines of life expectancy is still going up for the latter three countries, while where HIV is highly prevalent, you saw a steep decline of life expectancy since 1980 when HIV got a pandemic. And you see now Zimbabwe is a bit stabilizing. That's because there's since a couple of years the treatment is free for everybody there. So yeah, still life expectancy got a lot worse for people living in countries where there's not a lot of health care. So the natural course of HIV infection is healthy people get infected. The HIV virus will replicate and will lead to immune deficiency, and this immune deficiency makes you prone for opportunistic infections, and if nothing's be done, then leads to death. And there's of course a couple of moments where you can intervene. So prevention, a lot of this is done, sadly not always in the good ways, well, still a lot of work to be done in the prevention area. The antiretroviral therapy, which has become a lot better in the last years. And of course you have the symptomatic therapy. Once people develop severe HIV and develop these opportunistic infections, we can do a lot to treat them, like giving cotrimoxazole to patients with pneumocystis pneumoniae, and of course, we can also, if we see CD4 counts are too low, so these people prone for infections, we can try to prevent these infections as well. So this is a slide with the a natural course of HIV. You see in the left bottom corner the infection. With in the first couple of weeks, the RNA load in the blood is going steeply up. So this virus enters the body, will replicate and replicate, and you will measure higher loads of RNA of the HIV. But then the immune system, this is the next line I got into the slide, is the CD4 cells. CD4 cells, this the T lymphocytes, will be in the beginning will get destroyed by the HIV virus, so they will be going down. But then they find a sort of equilibrium where they can control the HIV virus, so it won't replicate any further, but they can't eradicate it from your body. So then you enter this period where HIV is latently there in your body, and a lot of people won't notice anything from it because your CD4 count is high enough to prevent having opportunistic infections, and you won't notice the virus. But replication will go on, but on a lower level, and will ultimately, in most people, overcome the immune system, and then will go, the CD4 count will go slowly down again. And at the lower right of the slide, you see when the CD4 count is too low, you get the opportunistic infections, and of course then people will notice, they will get ill. So when did we start treatment? Well, in the 1987, when we didn't have any antiretroviral therapy, we had to wait till patients got symptoms, and then we could start of course, the symptomatic therapy. But from 1996 on, we got the antiretroviral therapy. So the first reaction was to give therapy to everybody who had HIV. So we didn't look at CD4 counts or HIV loads. We started everybody on therapy. But soon we saw that this medication was very hard on the body. A lot of toxic effects happened from the retroviral therapy. Then we thought, well, maybe we should be a bit more careful to see which people actually need them. So we, from 2002 on, we thought, well, we have to check the CD4 counts and see if people are getting too low. So too low was below 350 CD4 cells. Then we have to start therapy to get the number of CD4 cells up. When you start the therapy, you'll have a going up of like 100 to 200 CD4 cells. Your count will go up by 100 or 200. So to prevent these opportunistic infections. And so 350 was the level until we waited to start therapy. But lately the medication has gone better and better, and there has been some investigation that as our HIV patients grow older, nowadays they reach also the age of seniors, so over 60, over 70, and now we see that diseases of the elderly, like coronary artery disease, or Alzheimer's, this kind of disease. And we see them on lower ages compared to healthy people. And this is why we are now prone to start treatment a little bit earlier than the 350. And nowadays, we say like when the CD4 cells are around 500, then you can consider starting. Depending on age, when you're patient over 50, you should start with CD4 counts that go below the 500. And the 350 is the absolute minimum, and between 350 and 500 there's a bit of some doctors say, well, we have to start at 500 already, and some say, well, I'll still wait to 350. So it's not a very clear defined boundary, but somewhere around 350, 500 you should start therapy. Well, a bit more about the HIV virus infection itself. You already heard me say CD4, the HIV virus infects the CD4 positive cells, and these are the T lymphocytes, CD4 positive lymphocytes, and macrophages, and also dendritic cells, and the brain cells itself might come affected as well. How is the virus built? Well, you have the outer lipid membrane, which contains a lot of glycoproteins. These are the purple ones sticking out. The GP120 glycoprotein is an important one, because this is the one who will first attach to the CD4 receptor on the target cell. And the GP41 will then help to better attach to the cell, so that the HIV particle can enter the target cell. Inside of the lipid membrane is this cone-shaped capsid, which contains 2 single strands of RNA virus. And also the HIV particle will bring its own integrase, reverse transcriptase, and protease enzymes. So it will bring that into the cell. Well, the CD4 is the main receptor on the target cell, but the HIV virus needs co-receptors to really attach to the cells. And for this is clearly a macrophage stated in the picture, because the macrophages have the CCR5 co-receptor. The T lymphocytes have the CXCR4 co-receptor, which is necessary for the HIV virus particle to properly attach to the target cell and then enter. This attachment will be followed by a whole cascade, was a bit too fast, a whole cascade of enzymes. I'm not sure if I can go back. Yeah, I can go back easily. A whole cascade which we don't know into detail how it works actually. Next one, I don't know if I can go forward now. Hope this one will work, because it's a good thing to see how it to see in 3D how it works. I think it will.
AIDS is caused by the human immunodeficiency virus, HIV. This is an enveloped virus. The envelope is derived from the host cell membrane with viral glycoproteins such as GP120 and GP41 inserted into the membrane as the virus leaves the cell. The core is composed of P24 capsid protein, and the P17 matrix protein helps maintain viral structure. Inside the core are 2 identical copies of single-stranded RNA viral genome and 3 enzymes: reverse transcriptase, RT, protease, PR, and integrase, IN. To establish infection, HIV must first attach to its host cell. Attachment occurs by interaction between GP120 on the surface of the virus and the CD4 antigen receptor on the surface of the host cell. In addition to the CD4 receptor, there must also be a co-receptor on the host cell. The co-receptor differs for different host cell types. In T lymphocytes, the co-receptor is called CXCR4, whereas on macrophages, the co-receptor is called CCR5. After attachment, the viral envelope and host cell membrane fuse, resulting in entry of the virus into the cell. Once the RNA is released into the cytoplasm of the host cell, Reverse transcriptase makes a DNA copy of the viral RNA genome. As the DNA is being formed, reverse transcriptase degrades the RNA strand. A complementary DNA strand is then added by the reverse transcriptase, and the ends of the resulting double-stranded DNA segment are joined non-covalently. Treatment with nucleoside analogs or reverse transcriptase inhibitors interferes with these steps. The resulting circular DNA is then moved to the nucleus and inserted into the host cell chromosome by the viral integrase, IN, enzyme. The integrated viral DNA is now referred to as proviral DNA. Following integration, the proviral DNA may remain dormant, or with host cell activation, RNA may be synthesized from the DNA, yielding messenger RNA and viral genome RNA. Viral messenger RNA is translated, yielding viral enzymes and structural proteins. Some of the functional proteins are formed by cleavage of a long polyprotein by the enzyme protease. Protease inhibitors interfere with this step. GP41 and GP120 are inserted into the host cell membrane, and the structural proteins surround the viral RNA to form the core. Finally, the virion is released by budding.
Okay, so I thought this was an illustrative movie for you. I hope it was. Could you hear it properly? I hope so. So I can skip this one because this is the backup slides for if the video wasn't working. So I'll go a bit farther through these and go to the antiretroviral therapy. We have a lot of different kinds of medication who will interfere with different steps in the HIV replication. So if you have this slide again with all the steps of HIV, first you have the fusion inhibitors, the CCR5 inhibitors. Of course, you must know that in your patients, the HIV which affects the patient is the one who uses the CCR5 co-receptor, otherwise this medication won't work. The fusion inhibitors who interact with the fusion of the virion with the target cell. We have the nuclease reverse transcriptase inhibitors and the non-nuclease reverse transcriptase inhibitors who will interfere with the reverse transcriptase, of course. The integrase inhibitors who will inhibit the DNA to be integrated in the genome of the host cell. The protease inhibitors who inhibit the forming of a new virion. And maturation inhibitors are currently under investigation now. We don't have them in stock to treat, but the maybe new ones coming up. So what do you want to do? Of course, you want to prevent development of HIV to severe HIV and AIDS by keeping up the CD4 cells and by suppressing the HIV viral load, of course. And in this way preventing the new infections and improve the length and the quality of life. Okay, this is a whole the medication we have in the different groups of medication, and when in the first years of treatment of HIV we had to give a lot of pills, a lot of burden of pills each day, but nowadays a lot of more combinations are being made. So lamivudine and abacavir are being grouped together as Kivexa. We have the Comivir, the Truvada, and well, I will show you all the pills. The best ones are Tripla and the Eviplera. We have nowadays is one pill a day. So each day one tablet can not cure but control HIV infection in the patient. You must always combine the medication. You can not give just medication from one group and give just one kind. because the HIV virus is a slobby virus when it's replicating. It makes a lot of mistakes, and this is why it will become resistant to your therapy. So what happens if you don't give 3 medication at a time? Here you see the bottom red line is the viral load, which in the beginning of this slide is nicely suppressed by 3 kind of medications. The 3, I don't know the word for it, sorry. The 3 bulk, what's the word for bulk? I don't know, sorry. The 3 bars, thank you, in the bottom of the upper side of the slide. One of the medication is stopped. Sometimes we did this in the past when we wanted to switch therapy. We stopped one of the medication, but then you see the 2 other ones, the virus can become resistant for it. So you see the viral load is going up. Well, then you say, we start another one to add up, and you see first it will work. The virus will react to it and will become suppressed again. But then actually you're giving monotherapy, because the other medication the virus is already immune for. So after a while, a couple of weeks maybe, but the virus will go up because you created a resistance for it. So we know that there's a couple of steps necessary to become resistant, but you must always combine the medication together. So what are the combinations we give? Well, in the first years we gave 2 NRTIs, but we saw a lot of resistance, so nowadays we always give 3 a medication, a combination of 3 medication from 2 groups. 3 NRTIs is possible. We don't use it often in Holland, but you have to give 3 medication always. The ones preferred in Holland is 2 NRTIs and 1 NRTI, because of the higher the higher steps necessary for the virus to become resistant if something goes wrong with the absorption or the intake of the medication. Big problem is the side effects still. Although the side effects have been reduced since the early antiretroviral therapy, but there's still a lot of side effects. So when you choose a regimen for HIV with a patient, you must discuss the side effects with this patient. A lot of times we start with efavirenz Truvada, but efavirenz is known to have a lot of side effects on the mental area. So if you know your patient has already been depressed in the past, then you better not choose the efavirenz, because it can, especially in the beginning of the therapy, can get a bit of depression in your patient. Well, if you know your patient's already prone for it, you shouldn't give this, because we have seen suicides with efavirenz prescription in patients. Lipodystrophy is the one where the fat in the face was decreasing, and where the fat in the back, the buffalo hump, would come up. And we saw that with a lot of old medications. So statidine is not used a lot nowadays, but a lot of people found this a very negative effect of the therapy. And of course the nausea, anemia, allergies. So when you start patient on therapy, you have to check them in 2 weeks to see if the liver is still functioning properly, if the kidneys are still working. And you have to instruct your patient that you, when they notice the skin problem, they should warn you. So there's a lot of cooperation needed from your patient. So a patient must be willing to adhere to the medication and to, especially in the beginning, come a lot to your outpatient clinic to check up on how it's going. So it's in the big lines how we treat HIV nowadays. It's now possible to treat HIV with just 1 pill a day and reach the same age as we healthy people do. So I'll go over to the hepatitis C treatment. Still time. So hepatitis C also an RNA virus. It's from the family of Flaviviridae, which come from the word yellow in Latin, as well as the dengue virus and the yellow fever virus, also Flaviviridae, because people would become yellow when they got hepatitis. And the genus is the hepatitis virus, of course, from hepatocytes, which they will infect. There's 11 genotypes, but there's 6 more who cause infection in humans. It was first in 1975 where it was known that there was another virus causing hepatitis, so it was called the non-A, non-B hepatitis virus, and not until 1989 the actually hepatitis C was discovered. The parts of the genotype I have another slide for, so don't look too much at that. Prevalence in Holland is now 1%, which is quite a lot actually, I thought, but mostly in the intravenous drug users, we see them in practice. Worldwide, there's 180 to 200 million people infected, and it's one of the most known reasons for liver transplantation because of cirrhosis and hepatocellular carcinoma. Prevalence, again in Africa, but now the northern parts of Africa are more, it's more prevalent, but also southern parts of Africa and in Asia, a lot of hepatitis C, prevalence from up to 2%. In Holland, it's, as I said, around 1%. This is the ones I was talking about, the genotypes. The genotype 1 we see most often in Holland, 1 and 2 and 3, in Holland and Western Europe, I have to say. And also in America, North and Southern parts of America, genotypes 1, 2 and 3 are more prevalent. As you see in Egypt, genotype 4 is the one most abundant. I thought this was because a mistake was made in a vaccination campaign where a lot of people got infected by the genotype 4 because of this vaccination campaign. The genotype 5 we don't often see in Holland, you see that a lot in South Africa. Genotype 1 and 4 are more harder to treat. Genotypes 2 and 3 are easier to treat with medication. How is the virus transmitted? Blood transfusions before we screened for it, before 1992. So a lot of patients in Holland had become infected because the hemophiliacs who had to use a lot of blood transfusions before 1992. A lot of patients, well, I have to say a lot of our hepatitis C patients are hemophiliacs who received blood transfusions, but also the intravenous drug users. Unprotected sexual contacts, we see that a lot with men who have sex with men, and via mother-to-child transmission we also see transmission of hepatitis C. And from 10 to 30% of patients we don't know how they got it. Well, there is a lot of patients asymptomatic for HIV, hepatitis C virus. Sometimes they feel a bit tired, a bit of malaise. Sometimes they have a little bit of pain in the right upper part of the abdomen. Joint pains and muscle aches also might point to hepatitis C. But a lot of them don't notice they're infected. Well, if you examine a patient, a lot of time you don't see any abnormalities. But if it's a bit further developed, the disease further developed, then you can see signs of liver failure, liver cirrhosis. So that's actually the next slide. This one is saying that the hepatitis C can become obvious in skin abnormalities, lichen planus, vitiligo. But also glomerulonephritis can be caused by hepatitis C, again lymphoma and cryoglobulinemia. Later on in the course of the infection, you see the problems coming up from cirrhosis. So the bleeding problems, the liver failure, the spider navy on your patients, the little point bleeds with a little pattern of spider coming out of it. So that's what we see if you examine a patient with cirrhosis, of course. With patients we get infected, a lot of patients will become chronically infected. There's only 20% who will clear the infection spontaneously. From this 80% of patients who will become chronic, 80% will have a stable chronic infection, so the liver won't progress to cirrhosis. But 20% of them will progress into cirrhosis, and from them 75% it will go slow, but 25% of the patient will develop cirrhosis fast. Even more fast if you have hepatitis B, HIV, and alcohol abuse next to it. So these are factors who will put you sooner into liver failure and hepatocellular carcinoma and death, actually. So what? This is a slide of how cirrhosis develops. Fibrose grade 1. You see around the portal tracts, fibrosis so the scarring of the liver tissue will come up. This will progress. A few septa are formed. This is the lines you will see. And these will become more abundant. So that's the progression from fibrosis grade 2 to fibrosis grade 3. And once the septa connect to each other, so we call it bridging, then we speak of cirrhosis, of fibrosis grade 4, which is cirrhosis. Well, I hope this one also the film will work. So, skip the end after the shit happens and go to. So here's a virion you will see with the core protein inside the lipid envelope with one single strand of positively charged RNA. This will fuse with the hepatocyte due to a whole receptor complex which we still don't know exactly how it works, and it will become endocytosed into the target cell, and it will uncode, and the single strand of RNA will be released into the cytoplasma. Then it will be read out by the internal ribosome ribosomes, so of the target cell itself, and new proteins are translated from this RNA strand. There's structural and non-structural proteins, so structural to create a new lipid envelope, and the non-structural to cleave the large proteins into smaller proteins, which you see happening now, to form a new complex. So a new replicase complex, which will translate the positive strand and form it into new strands of RNA. It's actually RNA and DNA formed, which will be packed again in the proteins you saw earlier made, and is released again outside the cell. The HIV film I showed you earlier showed that this RNA would be translated to DNA and then integrated in the host genome. Hepatitis C doesn't do that, so the hepatitis C RNA won't go to the nucleus and into the genome of the host cell. It will stay in the cytoplasma, and that's why it's easier to treat than HIV, and we can eradicate it from the body, which is not the case with HIV because it's integrated in the genome. So it's easier treated, and you can try to eradicate it from your patient. Eradication is easier again in genotype 2 and 3 patients, which will you can see in the shorter duration of giving therapy to these patients. Unfortunately, we see most people with genotype 1 and 4 who are harder to treat. Once we started treating hepatitis C, we started with interferon alpha, which you had to give 3 times a week subcutaneously, not a lot of people actually cured from interferon alpha, and it had a lot of side effects. Once it became pegylated, so pegylated interferon alpha, you only had to give it once a week, so it reduced the side effects, but still a lot of side effects from pegylated interferon alpha. And once we combined it with the ribavirin, the treatment outcome became a lot better. I will have a slide of it to see the progression of success we booked in the hepatitis C treatment. But since I think last year, maybe last 2 years, new treatment is on the market in the form of protease inhibitors, and this is the Boceprevir and the Telaprevir, which we have now, which you will add to the ribavirin and the pegylated interferon alpha, who gives a lot better results for cure. I have a lot more slides of this, so I will explain to you. And there's still a lot of more new medication coming up, and the ones we're most anxious to see is the ones where the interferon will be no longer necessary, because this is the one who gives a lot of side effects. And so maybe in next year's time, maybe 2 years, we have a treatment where you don't need the interferon again anymore. Let's see. Yeah, okay. We use a lot of terms in the hepatitis C treatment area, and we always try to receive sustained virological response in our patients. That's the third dot from above. Sustained virological response means that after the end of your treatment, 6 months later, the patient is still clear of the virus. That's the sustained virological response, so 6 months after stopping treatment. once a patient was virus-free, but after stopping the virus comes back again, you have a relapse. You have a relapse. During therapy, we measure the hepatitis C load to see if the virus is responding. And if a patient has no more load after 4 weeks of therapy, we speak of a rapid virological response, the RVR. If at week 12 there's 2 log degrees of hepatitis C, it's an early virological response. So if in the week 4 it's still measurable, but then in week 12 it's no longer measurable, then we speak of early virological response. If you see this happening, so the early virological response at week 12, but again a detectable viral load at week 24, then we say this patient was a partial responder. If there's no response at all at week 12, then you speak of a null responder, and you can stop treatment. I'll go a bit faster over this because this is the old guidelines, how we treated hepatitis C before the Boceprevir and Telaprevir came to the market. As I said, the genotype 2 and 3 you can treat for shorter durations, only 24 weeks, and the other ones you have to treat for 48 weeks with pegylated interferon alpha. We have 2 forms, the alpha and the beta. The alpha you will give 180 milligrams per week, and the beta you will give 1.5. I said milligrams, I meant micrograms. And the beta is 1.5 microgram per kilogram per week. And the ribavirin is given in doses of 15 milligrams per kilogram per week, per day, sorry, or 800 milligrams per day, depending on genotype. This is what I told you earlier, the development of no treatment at all. So 1% of the patient will clear the infection. It's actually a bit more, but this was in a control study. First, interferon was the only medication we had. 20% of the patients with genotype 2 and 3 would become cured, but only 5% of the other genotypes. Once we started to treat patients for longer durations, you saw double number of patients who got cured. But with the combination therapy with ribavirin and interferon, the response got a lot better. And when the pegylated interferon got to the market, also the treatment response it got a lot up. But still you see the genotypes 1 and 4 are harder to treat than 2 and 3. Yeah. So we're very happy with the Boceprevir and Telaprevir because the responses to genotype 1 is going up a lot. I will show you in the next slides. It's actually only investigated in genotypes 1. So you can't give Boceprevir or Telaprevir, the protease inhibitors, to patients with genotype 4. It's not registered now. So only for patients with genotype 1. Okay, first we check if the patient has never been treated, so the naive patient, treatment-naive patient, or if they already received in the past medication for the hepatitis C. Because the approach is a bit different for both. So I will start with the naive patient, so the patient who has never been treated before, and I will start with the Boceprevir. This was a study done where they investigated control patients, so it's the lowest bar with interferon and ribavirin, so the standard treatment before 2 years ago, and this was given for 48 weeks. Then the other groups were given a lead-in period for 4 weeks of interferon with ribavirin, and then they started on Boceprevir. So the Boceprevir was added to the other two, so you give triple therapy after that. If the patients were undetectable at week 8, they stopped at 24 weeks of treatment, they stopped the all treatment. But if they were not undetectable at week 8, they would continue the whole length of treatment, the same as in the control patients. So this was the outcome of the study. You see the percentages of the sustained virological response. So after stopping of therapy, half year later, no virus in the blood. You see first the total amount of patients, and then the two other groups is Caucasian and blacks split it up. So the green bars are the control patients, and you see in all groups that adding Boceprevir to the treatment would give a lot higher outcome of sustained virological response. And the first and the second group I just briefly described. So the first one, you stopped after 24 weeks if a patient was undetectable at week 8. And you see that stopping early is actually giving the same response as going the whole length of therapy. So this is one of the advices given now. So measure your virological load at week 8. If it's not detectable, then you can stop after 24 weeks of treatment. What is also a remark you have to see is the rapid virological response I told you earlier. So this is if you are undetectable at week 4 of your therapy, you see that actually adding the Boceprevir, maybe you can leave that because you see the same response for the Boceprevir group as the control group, maybe Boceprevir a bit better, but you see that if your patient is undetectable at week 4 of the therapy, then he has a good chance of becoming to reach sustained virological response. And if it's not detectable at 4 weeks, well, the chances are still 1/3, so you can keep going on until the next measurement at week 12. And if week 12 is a good response, then you can continue and you have still 1/3% chance to be cured. But it's very important that you become undetectable early in the course of the treatment. The Telaprevir is actually not given lead-in, it's just started. And this investigation, or the study investigated a regimen where we gave 8 weeks of Telaprevir, 12 weeks of Telaprevir, or only the pegylated interferon and ribavirin. Again, if the patient was undetectable at week 8, they would shorten the therapy to 24 weeks. If it was not undetectable, it would you would continue to 48 weeks. And also here you see that adding Telaprevir to the treatment would get a lot better responses. So like up to 75% in total. And again, Caucasian people are a bit have a bit better outcomes than the black people. We don't know what caused that. Because the results of the 8 weeks of Telaprevir is the same as the 12 weeks, you can give for 8 weeks. Let me see. A note to this all is that cirrhotic patients, you can't give the shorter time period. You have to complete the whole 48 weeks. They are harder to treat. So What we do now is to control at 4 weeks of therapy and 12 weeks of therapy. If you're not detectable, then you can shorten the treatment after, you can stop treatment after 24 weeks, but not for cirrhotic patients. You have to go on for 48 weeks. Treatment experienced patient, I will go a bit faster through this. A lot of regimen was also investigated. This is for the Boceprevir. Again, a lead-in period of 4 weeks of double therapy, and then added the Boceprevir, depending on measurement of the RNA of 8 weeks. You would continue up to 36 weeks or to 48 weeks, compared to a control group who would be treated for 48 weeks. What we saw there is also a better outcome for the groups receiving Boceprevir. So also in the patients who were earlier treated with interferon or pegylated interferon and ribavirin, they would still make a good chance if you try it again with adding the Boceprevir to be cured. So, but what we saw was that patients who relapsed, so with the earlier treatment regimen without the Boceprevir, we had a good response, but they relapsed after stopping treatment. These patients have a good outcome with adding Boceprevir. It's the second lined bar complex. Non-responders, so the ones you treated but they didn't respond to your treatment with ribavirin and interferon, a lot harder to treat, but if they're undetectable at week 12, they still have a good chance, I mean 50%, 40 to 50% chance to become cured. And this is also the case for Telaprevir, adding Telaprevir. Which, if you see, this is split out to relapsers, no responders, and partial responders. You see the patient who did not respond to earlier treatment regimens still 33% to become cured if they're undetectable in week 12. And relapsers actually now with adding the Telaprevir have a good chance to like almost 90% to be cured. To sum up, patients who have never been treated with any in the past before and have genotype 1, we now give regulated interferon and ribavirin, and we have a bit of a preference for Telaprevir. So we treat those patients. Let's see overview of this. After we treated with Telaprevir, actually in a dose of 3 times a day, 750 milligrams for 12 weeks. Then we measure if if there's no viral load in the blood. At that point, you can go on. And stop at 24 weeks. If there's still a load, but it's had a 2 log decrease, then you can go on, but you have to treat for 48 weeks. Cirrhotic patients, you always have to treat for 48 weeks. And Boceprevir, if Telaprevir is not the first choice, that's actually with patients who have skin problems. So if you have a patient with sensitive skin, so eczema or other psoriasis, then you better not prescribe Telaprevir, because that's one of the side effects. I'll show you here. So you have to choose on the basis of side effects if you can give your patient Telaprevir, otherwise you give Boceprevir. And for all patients, if in week 12 you measure a viral load, you can stop treatment, because the chance of being cured then is very low. So the side effects is still a lot. Again, The interferon is one medication we would preferably not give anymore, but well, that's not up to now. We didn't make that. A lot of people are having flu-like symptoms, feeling tired, having aches in the body, especially the day and the day after the injection. Concentration problems, so it's hard to adhere to the therapy. Before you prescribe the hepatitis C therapy, we always send the people to the psychiatrist to screen if they're up to, if they're not depressed already or having other psychological problems, because we have to treat them then for depression as well, because otherwise they won't finish the cure. And in hospital we have a nurse who will be easily, they can call on easily to check if they have a problem. So it's a very intensive treatment period. But now with adding the new protease inhibitors, people have a fair chance to be cured for the hepatitis C. And a lot of new medication coming up for hepatitis C as well. So always combine your medication for both viruses, and we hope in the future to have better medication still. So this is what I wanted to tell you.